Folks, it's Thursday. You know what that means. Yet another version of this, one of my favorite hours of the week. If I say favorite hour of the week, then Prof. Rez will be very, very mad at me. Um, but yeah, very, very excited for version number many. And today, it's usually a day of firsts. And as you all know, this is a space where we honor and celebrate our beloved Academy members. And I've gotten a lot of emails about just the space, and we'll share with you that, that it takes a lot to get here, to get where Sarah is at. Often have joined VMR a long, long time, and then you hop in and you join the academy, and then you hang out with us a long, long time, and then we make sure you're ready for what is a difficult task to discuss a case in front of people that is recorded for life, and not to stoke the anxiety more. But Sarah's more than ready for that, and I know she's ready for it because she's already done it twice. But there's a little bit of a twist today, and that is her first time discussing an internal medicine case in front of a public recorded space. But she's more than ready for it, and I think nothing could capture more than what you've accomplished, Sarah, internally by the fact that you've already done this twice. And I think I get to say that very, very rarely. Sarah's been integral to what we do in CP Solvers. We try to be as diverse as we can be in all domains possible, including specialty. And Sarah is a future neurologist. But as is true for anyone who is focusing on one specific organ, you have to know the context and have to know everything else. And I can say this with frequent direct experience that her internal medicine skills would have her land in an IM residency program with relative ease. And so super, super happy to share the stage with you. And maybe I can hand the mic for you to say hello, and then we'll introduce everybody else.
Yeah, thank you so much for the introduction. I'm Sarah. I am from Emory, applying into neurology as mentioned. Um, and I just want to say this is just such a wonderful community, and it's an honor to learn from everybody here on such a regular basis. I'll also say it's my birthday, so I would
All
rather be doing
right.
nothing else
Happy
than being
birthday.
here discussing.
Wow, that speaks volumes. I wish I knew that before my intro. Oh my gosh,
Oh.
you're on your birthday. What are you doing for your birthday?
Well, nothing today. I have like one of the socials for a internal medicine transitional year, but
I see.
other than that, nothing tonight. I think I'll probably do something on Saturday, just go
That
get
sounds
dinner with a couple
awesome.
of people. But
Sounds wonderful.
for now, just this. Like
Yeah, there we
party with
go.
all of you.
There we go. No one better to celebrate your birthday with than if you ask me another He Moon case. He has presented so many incredible cases in the last couple of months. We're very, very lucky to have her today. Maybe before I hand the mic to her, we can thank the people who are making this happen, starting with Aaron, who's doing the scribing. Mic to you, my friend.
Hi everyone, I'm Aaron. I'm scribing today. He has another case, and yeah, can't wait to see what Sarah's discussing.
Guys, you should I keep trying to give you all incentives to keep joining and to hopefully join us in the academy. Aaron presented a mind-blowing case um, in the academy 2 days ago, and it's on my mind because Sarah, I don't think you were there, but it was an unbelievable neuro case of a patient who had non-ketotic hyperglycemia causing essentially focal epilepsy, high frequency of seizures. Yeah, maybe he has a neuro case, maybe not, we'll see. But let's thank Manaswini first. Manaswini, say hello, please.
Hello, everyone. Excited to be here. I'm doing teaching points today and looking forward to his case. And happy birthday, Sarah. Looking forward to your discussion.
Thank you, Manaswini. And another, I don't know, I learned this about Manaswini recently, Sarah. She is also in the bridge between internal medicine and neurology. Yeah, so there's more and more neuro love in this space than I'm realizing, which is wonderful. Last but not least, Mike, to you, he.
Yeah, I'm very honored to present this case to Ravi and Sarah. Sarah, happy birthday to you. When my attending mentioned this patient, I immediately thought of Sarah. Her wisdom will really shine through this case. I wasn't directly involved in this patient care, so I made a few small modifications. But yeah, this will be a wonderful case for Sarah.
You're too kind. You are very, very grateful for you. You didn't even see the patient, and yet you're bringing the learning. So really, really is an extra layer of gratitude for that effort. Alrighty, let's rock and roll.
Okay, let's just start. Okay, chief complaint is a 41 male with a left pressure palsy, left arm predominant hemi-neglect, and left arm predominant hemiparesis, left hemi-neglect, and right eye blurriness.
Oh my goodness. I've been selected to do a neuro case. I have to perform. Um, well, so I don't know if I heard the time course, but something that's really important to remember for any neuro chief complaint is time course informs any chief complaint that the person is going to present with. So for this 41-year-old male with left facial palsy, left hemiparesis, and left hemi-neglect, and then right eye blurriness, I would want to know how rapidly this came on. Is this something that was acute, where I might be thinking about a vascular phenomenon or a seizure that's affecting maybe the right side of the brain? Or am I thinking about things that are more autoimmune, like a subacute nature, something that could have been kind of progressing slowly and then eventually, um, coming out of this acute presentation that brought him to the emergency room? Or are we thinking about something that maybe has been there for a long time and now, like, we are hearing about it, but it's been there for a long time? Um, so those are kind of the first buckets that I'm thinking about are vascular, autoimmune, epileptiform seizure. And then, I mean, infectious things are always, they can do anything. They can go to the meninges. And then, of course, when there's any kind of effect on the meninges, you can see things that are not necessarily in a vascular territory, but affect a lot of parts of the brain. And then I would be thinking about the localization, whether it's central nervous system or peripheral nervous system, which right now, I don't know if I can obviously point to central nervous system, but neglect is certainly something that points directly to the brain. Um, so I think this is somebody who is going to get kind of the stroke workup. Probably came in as a stroke uh, stroke alert, but I'm sure that we'll hear more about what that presentation looked like and whether they got any initial imaging to rule out anything that would need immediate acute management. What are your thoughts?
Yeah, no, I think that's absolutely superb. You're illustrating that solving a clinical riddle is really about two fundamental questions. Is the first is where is the disease? And once you figure out where the disease is, you can start to be realistic about being able to figure out what it is. And I think neurology really does a great job of breaking it down to that fundamentals, but we do that with everything. If somebody comes in with abdominal pain, we first have to pin it on the pancreas before we think we then subsequently pin it on IgG4 disease. Um, which we would do in VMR. In real life, we would pin it on alcohol use. Um, and so I think the exercise here, in terms of what information we know, what are you finding easier to do right now? Are you finding it easier to think about the what this disease is, or are you finding it easier to think about where this disease is?
I think right now I'm finding it easier to think about the where.
Yeah,
Because mostly because of the like palsy plus neglect picture
yeah,
that
yeah.
rings some bells for brain parenchymal
Right,
disease.
right.
Um, but I think we'll hear more very soon.
Yeah, I completely agree with you. It's so much easier to think about the where, and I think it's almost too easy, right? Like you got
Yeah.
neglect, and the truth is, in reality, Moon's doing a little bit of a favor by saying that there's neglect phenomenon. The truth is that a patient wouldn't come in and tell you that they have neglect, right? So, you'd have in real life, you'd have even more difficulty with both those questions. But neglect is a very high order cortical phenomenon, and so you can essentially localize the lesion to involving the right temporal parietal cortex. And that is exactly the location where attention exists and visual spatial attention exists. And so if you had to ask yourself, are there any counter arguments to that localization? Um, the things that give you a little bit of pause. What do you think?
I mean, right now, not really,
Yeah.
because there are tracts to like right visual field from the right part of the brain. So Um, I don't know. I or am I?
Yeah, there you go. You've got it.
I always bring up like the picture when I think about visual fields because it's
Yeah.
sometimes hard to think about it. But I think right now I would be really interested to hear about the time course
Yeah.
to kind of nail down what's going on.
Yeah. If you engage in reflexes, right? So you latch onto something you're like, I'm not sure what to do with that. So let's practice reflexes.
Mhm.
If a patient has crossed signs, right
Mhm.
eye, left hand,
Sure.
what reflex does that trigger in terms of localization?
Like
Yeah,
brainstem
exactly. Yeah,
things.
exactly right. So there you go. There's your friction point. You're like, wait, neglect, right,
Yeah.
temporo-occipital lobe, crossed signs, brainstem. Huh. The other thing that's interesting is that if we take at face value the chief concern, this is right eye, right? Not right visual field. And the other thing that I find very, very interesting, Sarah, is the word blurriness.
Mhm.
So when you're thinking about blurriness, um, that it's very, very unusual to find a neurological cause for true blurriness. What is true blurriness? Blurriness sometimes is used for other more specific visual symptoms, like when people lose vision, sometimes they use the word blurry.
Yeah.
Or when people see double, sometimes they use blurry. Those visual loss and diplopia have very different approaches. But if somebody truly has fog in their ear, meaning that they can see, but they're mist in the way, that is very often an intraocular pathology. And the one that you'll get tested on in medical school is a patient who's hyperglycemic, who has their lens that dehydrates from the hyperglycemia, and now their lens doesn't focus the disease very well. And so they get blurry vision. But it goes to show you that there's something in the way of the light hitting the retina rather than the nerves translating what that signal means and turning it into a visual phenomenon.
Mhm.
There are, however, two important neurological causes of blurry vision. One is much more common than the other, and that's optic nerve disease. And you can imagine when the optic nerve is inflamed, engorged, unhappy, it can actually distort the quality of the image rather than the quantity of it. And then the other is when you have autonomic dysfunction that affects your pupils. And if your pupils aren't kind of constricting and dilating appropriately, you get into a lot of trouble. So I'm right there with you. I think this case gravitationally pulls you towards the contralateral cortex. But I'm slowing down a little bit, saying, how do I know the patient has neglect? Is it really neglect?
Yeah.
What about the right visual symptoms? Are these actually cross signs, which would make me go to the brainstem? Or are the eye signs not even neurologic because they're blurry and blurry plus neuro uh, is unusual, though of course they may be visual loss or double vision. I would say initially my honest answer was the what? I don't know what this is. I don't know the time course. I don't that's difficult. The where, I was like, okay, right temporal cortex on the surface. But when you look at it with a microscope, you're like, I can see so many traps here. So
Mhm.
my honest answer is I have no idea where the what is, and I have no idea where the where is. And hopefully more information will help us clarify that.
Right, amazing discussion. Yes, so HPI will give some answer to Sarah. Sudden onset deficit occurred 6 hours ago, and right eye blurriness began several days earlier. The patient reported 3 months of joint pain. At the time, RF was positive, but CCP was negative, with no improvement on NSAID or steroid, along with a headache, myalgia, mild fever, chills, night sweat, malaise, and decreased appetite. The patient denied a jaw pain, scalp tenderness, palpitation, shortness of breath, chest pain, recent dental procedure, dysuria, URI symptom, or IV drug use. I will stop here.
Oh no, where is Jeffrey when we need him? So now we've got our a little bit more of our time course, maybe 41-year-old male with acute onset of neurologic deficits and the background of a, I guess, chronic, 3-month history of what sounds like um autoimmune in nature, but and maybe it's rheumatoid, but it's CCF negative, CCP negative. So um, some type of autoimmune systemic illness, um, potentially. And the other things that I might be thinking about here with this, long history is this a chronic infection too that maybe we haven't nailed down. Um, so I guess I would be trying to figure out maybe like making a table, like if I had this patient in front of me, trying to draw that time course. When did they first start having these symptoms that are more systemic? What what things fall into that category, whether they're, like tuberculous disease and uh, all of the endemic fungi that can also be brain and body. And then uh, for this acute onset, is this the first time that there has been movement across the blood-brain barrier? Um, like, are we having an acute onset of new infection, or is this kind of an autoimmune thing that's been smoldering for a long time and then finally has reached a point that we are now having symptoms that are CNS? Um, Again, I'm not sure that I'm going to get very far with that until we have a little bit more information about labs and also like family history, whether there's any like known autoimmune in the family or anything of that sort, as well as like travel. So like travel can inform what illnesses people are at risk for, or like whether they've gone hiking and could be at risk for something like Lyme. So, uh, what are your thoughts hearing about this?
Yeah, I have nothing to add really of substance. My goal is to just try to help you see things with more simplicity.
Hmm.
Because I think it can be kind of overwhelming to get lost in the range of possibilities. And so let's just go back to that very simple principle, the what and the where.
Hmm.
So focusing on the where, what progress have you made on the where, you think, sort of big picture wise?
Yeah, big picture wise, I think systemic illness
Yeah,
with
yeah,
with new neurologic
yeah.
component.
Yeah, I'm so grateful for he for presenting this case because it illustrates exactly what I was sharing about you is that like you intend to be a neurologist and by virtue of being in the space and showing up to so many internal medicine sessions, this case is proof that you have to be a really good internist in order to advance your neurological skills. And you're right, this is a systemic disease with neurological features. I think the open question, Sarah, is this a systemic disease with ocular and neurological features? The neurological features are without doubt. The ocular features are either pseudo-ocular in that they're neurologic mapping onto the eye, or they actually are a separate entity affecting the eye itself. And so that's an open question in my mind. And I'll share with you a very simplistic approach about systemic diseases. And you can think of systemic diseases in two separate categories. Either they're systemic because they're in blood vessels, and the reason they're systemic is the system that they're in, the cardiovascular system, is actually inherently widespread. Or they're systemic in that they are multifocal, meaning that they exist as patchy diseases outside the cardiovascular system in independent organs. So an example of this, Sarah, would be a patient having metastatic lung cancer. It's in the liver, it's in the lung, but it's outside the blood vessels. So if you were to take that simplistic approach and use the information you have now, are you making any progress on where this systemic might intravascular or extravascular? What do you think?
I mean, my immediate thought would be like intravascular,
Yeah,
because if it's starting systemic and then getting into the brain, it
yeah,
has to get there somehow.
yeah, perfect.
Um,
Yeah,
and then I think this does make me think of something like, vasculitis, um, that can appear anywhere.
yeah,
So,
yeah.
uh,
Yeah, I think you're making a very powerful argument. Like, how do things get to the brain unless you have literally like a hole through the skull, which unfortunately happens with some cancers or contiguous spread of sinusitis? It has to get there through the blood. And so you're pushing me to be more clear because I think if you think about how lung cancer gets to the brain, right? It gets there through the blood. But
right.
at least as far as our ability to technologically detect the lung cancer, we often are unable to find any remnants of it in the blood. So it
Mhm.
almost is like hematologically disseminated, but leaves no intrinsic trace in the hematological system.
Yeah.
So if you grant that little sort of educational leeway of intravascular, meaning it's still in vessels,
Mm.
or extravascular, meaning it may have traveled through vessels, but the disease is primarily outside of blood vessels. What do you think about this case?
Yeah, I mean, probably, I mean, it could be outside the vessels as
Yeah.
well. I really know that we're having like uh myalgias and
Yeah.
fevers and
Yeah.
so I think it can be anywhere, which, you
Yeah.
know.
I think odds are that it has a strong extravascular component given all these
Yeah.
uh, like non-pure vascular symptoms. I'll ask you to incorporate the abrupt onset neurological syndrome. How does that influence your calculus about intra or extravascular?
Yeah, I think I think I've trained in a place where there is a lot of stroke.
Yeah.
So anytime that I see somebody who has an acute presentation of something that may
Yeah.
be in a vascular territory, I think
Yeah.
of vessels. Um, so that's my knee jerk.
Yeah. Most systemic diseases are extravascular diseases. It's very rare and often very difficult to diagnose, say, vasculitis or endocarditis. Um, and here, this is the beauty of neurology, is that abrupt onset focal disease is such a powerful clue to an intravascular process that this patient almost certainly has something in their vessels.
Mhm.
And the question is the entirety of the disease an intravascular process, or do we use the arthritis and the ocular symptoms as clue that the disease also exists outside blood vessels?
Mhm.
The problem, Sarah, is that both these symptoms, visual symptoms and joint symptoms, can easily be fake outs. Your joints hurt and ache because you have endocarditis. Your
Yeah.
vision is gone because you have a sort of blockage in your retinal artery, or you have metastatic infection and you have endophthalmitis from endocarditis. So for me, I think it was almost impossible to try to figure out where this disease is systemically before the abrupt onset of focal neurological symptoms. Because the patient has eye symptoms, joint symptoms, this could be rheumatoid arthritis, could be spondyloarthritis. But the moment that happens, you're like, I know there's a systemic disease. So the only question that I'm grappling with is how much of an extravascular component is there to this disease? That remains to be determined. But now the question is, we know there's very likelihood that there's something in the intravascular system. Where in the cardiovascular system? Is it in the heart? Is it in the carotid? Is it in the veins through a PFO? Uh, but the advice that I would share is exactly what you said. You said this is a systemic disease with neurological involvement, maybe ocular involvement, and take advantage of the fact that systemic diseases essentially come in two flavors, outside of vessels or inside of vessels, and the history can really help you make a lot of progress. So another example, if you see palpable purpura in the context of a systemic disease, that's a problem inside vessels. If you see the patient having painless jaundice in the context of a systemic disease, that's probably an extravascular hepatobiliary pancreatic process. And so here, I'm really, really worried about something in this patient's blood vessels that is systemic. So we'll see where that journey takes us. Any questions or reflections about that?
No, I really love that you brought up endocarditis because that does tie together some of these symptoms well.
Yeah.
And I'm excited to hear more from he.
Yeah. As always, endocarditis until aliquot 17 in real life will be very rare. But when you have fever and a vascular phenomenon, you have to bring it up to maybe aliquot 5. We're still
Wow.
in aliquot 2, so a lot of work left to do. But I certainly would be starting to worry about it for sure.
Yeah.
All righty, Mike, to you.
Yeah, amazing discussion. The teaching point half is filled. Yeah, so let's go to Pamela, past medical history, not really significant. Family history, not significant. He's a social drinker and he smokes like one pack per day for 20 years. And also he lives in United States and he haven't traveled recently. He has no allergies. Going to the physical vital signs, temperature is 37.5, heart rate is 95, blood pressure is 150 over 90, respiratory rate is 20, saturation is 96%, HENT decreased right eye visual acuity, and a pupil equal and round reactive to light. and extraocular movement is intact, no JVD, no lymphadenopathies, cardiovascular, holosystolic glowing murmur at the apex, and neuro exam, decreased right visual field, left central facial palsy, like forehead sparing, and left arm dominant hemiparesis, like 3 out of 5, with hemisensory loss and left neglect, hyperreflexia with the left Babinski sign, extremity and skin, mild joint tenderness without swelling or warmth, range of motion is preserved. I will stop here. And NIHSS was 15.
Sarah, I'm not to jump in, but I think usually we do breakout rooms closer to the end for when we're trying to figure out a diagnosis. I honestly think this is an amazing time to have a 3 or 4 minute breakout room because the case has gotten really, you have an abrupt onset neurological syndrome. There's a lot to think about and a lot to do. So maybe you can jump into a breakout room, share your thoughts, and uh, capture the power of everybody else. We'll reconvene in 4 or 5 minutes. Does that sound okay?
Yeah, sounds good to me.
Awesome. Okay. All right. Do a little break.
I can't hear you.
Oh, so sorry. Thanks, Eugene.
You're welcome.
So Sarah, what was it like? What was the conversation with Eugene at all?
Yeah, I think we discussed a little bit about making sure that we are really certain about what the visual symptoms are, whether it's true blurriness, visual, like a visual field deficit that is what it sounds like, um, or like whether it affects just a single optic tract, um, like optic nerve, excuse me. And and then just discussing the difference between like a crossed sign that localizes cleanly to the brainstem, or if you have like infective endocarditis and you have clots that are being thrown to multiple vascular territories, because that can also cause this kind of, you know, wrong eye for the cortical sign that you see. Uh, but but yeah, I still want to know, um, with this holosystolic blowing murmur, is it new? Is it existing? And then probably we're going to see some imaging results to further clarify what's going on at the valves and um
Right.
yeah. So yeah, that's where I'm at.
That's superb. It adds so much diagnostic progress. I think we can jump to sort of therapeutic management. So, if I were to make this case more challenging just for practice and say the patient presented not 6 hours ago, but 6 minutes ago, do you think you would give him tenecteplase or TPA?
Yeah. So this person, I would be very tempted to.
Mhm.
I would probably see whether they have, um, I mean, they have a maybe large vessel, syndrome, maybe not. So I would definitely be sending them to imaging immediately. Uh, And then I think you can give TNK even if you think that they're going to go to thrombectomy. So I would maybe lean towards it.
Awesome. Follow-up question for you. Uh, I think that's probably what most people would be thinking about. I'm curious, how does your hypothesis of endocarditis influence that calculus?
Um, I can't remember if it's a contraindication or not.
Yeah, let's practice. So,
Yeah.
what are the complications that you know of that endocarditis can do to the brain blood vessels?
It makes them more friable, more
Yeah.
likely to bleed. So I
Yeah.
mean, it would make sense for it to be a contraindication, but
Very
yeah,
difficult decision. We don't know this patient has endocarditis.
yeah,
If they do, then what could be happening is they could have a mycotic aneurysm waiting for that TPA to come and say hello
yeah,
and then gush into this patient's brain. So this is a very, very difficult management case, and it goes to show you how important it is to be a very good doctor, period. Not a very good neurologist or a very good infectious disease doctor or a very good cardiologist. You have to be a doctor, and a patient doesn't come with a brain separate from their heart. And if you think this is a stroke, it also shows you how important it is for you to understand what the mechanism of that stroke is.
Mm.
And if the patient is having an ischemic stroke because there's a whole bunch of pus in his right MCA, what's TPA going to do to a whole bunch of pus? Nothing.
Yeah.
It's not tissue pus activator, right?
Sure.
And so that's the tension in this case. You get no benefit and you get complications.
Yeah.
So I don't know what people would do in the situation. I probably wouldn't give them TPA. Why? It's because we've accumulated enough concern for the possibility of endocarditis. And that's why it's so, so important to be a really good generalist, no matter what specialist you are. And I think this case illustrates that so powerfully.
Yeah.
The risk, of course, is being overly thoughtful and overly analytical. And his patient just has ischemic stroke from uh, a chronic mitral regurgitation causing him to go to AFib.
Mhm.
But that's why it's so important to analyze the foreground. This is not just an abrupt neurological syndrome in a bland background. This is an abrupt neurological syndrome in the context of fevers, night sweats, joint pains. And that really ups the ante for the possibility of a non-bland thrombus. And so, yeah, I probably wouldn't do it. I think what I would do in real life is get a CT, CTA. I don't know the data for thrombectomy in patients with endocarditis. I imagine mechanistically, why not suck out the pus if you can, but I don't know. That'd be something that this case will prompt me to learn afterwards.
Yeah.
Um, and then empiric management for endocarditis, I probably would start it now. This is good practice. So, what's in your toolkit for empirically treating endocarditis when you don't know the bug, the potential bug?
Ooh, good question. Uh, I would think that I would make sure that I'm covering staph
Excellent.
because it is so common and also destructive.
Yeah.
Um, and I mean, by covering staph, I'm going to cover strep. So I'm giving vancomycin. Um,
Beautiful.
and and then other things, probably doxycycline. And then um, yeah, it would be broad spectrum antibiotic. Um, at least to start, and blood cultures.
Yeah, definitely.
And I guess besides that, can't remember what's in the toolkit.
Yeah, let me arm you with these reflexes. So the reflex is Vanc ceftriaxone.
Makes
Here's
sense.
the why. Yeah, here's the why. So Doxy is a great thought. Doxy is a really good medication for the sneaky intracellular culture negative endocarditis bugs. Thankfully, because they're sneaky and culture negative, you don't need to treat them empirically, meaning
Okay.
that they're so slowly progressive that even if you give them a dose now, it's going to take you treat them for like a year.
Oh,
Um, so what do you need to cover empirically? As you said, vanc, vanc, vanc for sure. The ceftriaxone is for the rare but real possibility of patients having gram-negative endocarditis, so patients with Klebsiella, with the Haysick organisms, but also because it actually is a little bit better of an antibiotic for patients who have strep infections and MSSA. It's more cidal and more killing than vanc. So vanc will get you your MRSA, um, but the ceftriaxone is a very, very effective tool because of its cidal activity for strep and MSSA. So just if you can't, don't have time to think, endocarditis, vanc, ceftriaxone, and then move on.
okay. Sounds good.
This has only been probably like 10 minutes in the ER with a quick history and an exam, and we've already talked for 40 minutes because of how educational this case is. So hand the mic to you for the next aliquot.
Amazing discussion. Yeah, a very important point you guys point out. And Aaron, if you can share the image, I'll be really appreciated. Like, I'm going to share the brain imaging, MRI, and also the optical tomography. The reason that we didn't use TPA, maybe we'll give the answer from the brain imaging, and also um, yeah. Sarah, do you want to go for it?
I'm so glad you're here, Sarah.
Well, I will do my best as again, I'm definitely no expert. But I'm seeing right cortical hyperintensity that is really kind of peripheral in the kind of sulci everywhere. And it doesn't really appear to be affecting like a whole vascular territory. Like it does look like little bits that have been
Mhm.
thrown, which really I think would lead us back to this is centered from the heart. And then thinking again, if I'm seeing that, if I'm concerned for that, I would be scrolling up and down to find,
Mhm.
you know, left-sided lesions as well. And then also trying to find the lesion that I think is pointing towards the right visual field too, um, because
Beautiful.
that was also a symptom.
Beautiful. I have nothing to add. Awesome.
Okay, next one, Aaron.
Ooh, this is not my wheelhouse. The eye is so cryptic. But is this a central retinal artery occlusion? Is that what we are seeing here? Or are these um like the are they called Roth spots that you get? I'm not sure. I would need
Sarah, you're not
optical.
alone. I have no, you know, last time I saw her interpreted this is like, oh my gosh, feels like 1863. I don't know. Yeah, I should probably shouldn't say anything because my confidence is like below 50%.
Yeah.
So maybe, maybe you can enlighten us both.
Yes, brain imaging DWY MRI was showing the multifocal small high signal intensity lesion in the right frontal and parietal lobes, consistent with embolic infarct. And I didn't show it to you, but T2 MRI was showing multiple cerebral microbleed in the both hemisphere, compatible with a septic emboli laid with a hemorrhagic lesion. And also, Sarah asked for the murmur, so that was a new murmur. And Doppler was done, normal carotid flow with no stenosis or plaque. Bubble study was done, no PFO or intracardiac shunt. EKG was normal, and Holter was the sinus rhythm. And then the SPOCT, the tomography of right eye showing the retinal hemorrhage and the Ross spot. I will stop here and yeah, if you can share a little bit more, that'd be wonderful.
Yeah, of course. He just just for timing, real quick,
Mhm.
Sarah, is he how many Alquast do you have until the final diagnosis?
I think I can make it two.
Okay, awesome. All right, Sarah, where are you at?
Ooh, I think that the diagnosis of an infective endocarditis is staring us at the face. But I think this retinal hemorrhage uh, is probably the thing that is causing our right-sided blurry vision. I'm I am interested though, still the neuro exam said visual field, which I the visual field, if you are like just as a it needs to be tested in both eyes. And it seems like maybe it wasn't. But so if it is the case that it's really just the right eye that is affected, um, that that's good, I guess. Uh, and then yeah, I this person, it's the same thing I think that we were discussing before. Um, what new information are you taking away from this, or are
Yeah,
you
no,
changing your management?
yeah, I think Sarah, it just really illustrates the idea that whenever you're trying to solve an eye complaint, we often say, is this an optal problem or a neuro problem? And this case illustrates that it can easily be both because they have the shared vasculature from the carotid supplying both the eye and supplying the brain or a large part of the brain. And so you can easily see how somebody has both. And I think this is a powerful example of being very detailed with your assessment because this patient has a neurological syndrome and a separate intraocular disease process. And yeah, I think when you see bilateral hemispheric emboli strokes with hemorrhage and in the eye, you really start to think of a cardioembolic source. And I think if you don't know anything more about this patient and you're just staring at their MRI, you see that they have emboli. You see they have occlusions in both hemispheres, so you naturally conclude that the common denominator is the heart. And I think the microhemorrhages gives you a clue that whatever's coming from the heart isn't a simple bland thrombus because it's actually blocking vessels, but then the inflammation that is coming with the thrombus is eroding into the blood vessel wall, making it bleed. And I want to emphasize that point is when you have a thrombus, it just blocks and doesn't cause hemorrhagic conversion unless the tissue itself is so large that it's friable and bleeds. But if you have small microhemorrhages, it tells you that the piece that came from the heart has an inherent inflammatory component that is eroding into the blood vessel in addition to occluding it, causing it to bleed. And so whenever you think about uh, inflammation plus thrombus, your hypothesis should initially start with infection, though there are inflammatory lesions that can be autoimmune, like Liebman-Sachs endocarditis, or malignant, like Morantic endocarditis. But the default hypothesis is infection. And so, yeah, I'm right there with you. I think endocarditis is a very leading consideration, but I'm drawing a blank on one thing, which is why would this 49-year-old man develop endocarditis? And I think that's probably the gap in that theory is why. What's your take on that? Any thoughts on why he might be having this disease?
Yeah, I think we don't have any information about existing valvular disease or known valvular disease, but there are
Beautiful.
things that cause the valves to be intrinsically susceptible, like maybe he has some kind of unknown anomaly like a bicuspid valve
Yeah.
or something of that sort. And then I mean there's the other things that maybe we're taught in school that are not always the case, but the, he is a little bit younger than the screening age for colon cancer, but
Right.
I I would maybe be thinking about that as well.
Yeah.
Um, and then, I mean, he smokes and he's
Mhm.
got like a pretty significant smoking history. Whether that has, given him accelerated vascular
Mhm.
aging, um,
Yeah.
yeah, I those are my initial thoughts.
Yeah, I think they're absolutely superb. What endocarditis is an unhappy marriage between a bug and a pre-existing cardiovascular vulnerability. And some bugs are so aggressive they don't need a pre-existing cardiovascular vulnerability like Staph aureus. Um, And so you are very wise in that you're saying maybe he has a pre-existing but subclinical cardiovascular vulnerability, or maybe he has a vulnerability to bugs that we don't appreciate yet. And so we asked about injection drug use. One of the most easy places to overlook is the teeth. And
Oh,
looking back and seeing that he recently had a dental procedure, which I had completely forgotten about,
yeah,
it certainly evokes the possibility that he has oropharyngeal source for his endovascular phenomenon. But I'd say that whenever you're really trying to make a compelling case for a diagnosis, you have to figure out not just the what or the where, but the why.
yeah,
So the where we thought was right parietal occipital area plus minus ocular, and that's been confirmed. The unifying theory of both those diseases is a cardiac embolism. The fact that that cardiac embolism has inflammatory features on history and on the MRI with microhemorrhages has us worrying the patient has an inflammatory cardioembolism, the most common of which is endocarditis. And now the why may be related to a dental procedure. So it's really starting to build case for that possibility. Um, but yeah, let's see what he has in store for us.
yeah. Did he deny recent dental procedure, or is that a positive on the ROS?
Dun,
Oh
dun,
yeah,
dun.
yeah. It was he denied a dental
Oh, okay.
procedure. Yeah. So okay, somehow.
The
Okay.
why is a mystery, Sarah. Great catch. Thank you for that. Yeah, I think that just makes it even more interesting, right? Like, why is he getting this disease? And I think
Yeah.
let's see let's see what information He Moon can help us because that's definitely a big vacuum that we should try to fill.
Okay, yeah, so let's go for the labs that I am going to mention. The WBC was 11K, hemoglobin was 8.6, MCB was 84, platelet was 167K, and coagulation panel was normal. BUN is 32, creatine was 1.23, elevated from the baseline. CRP ESR was elevated, UA was showing the mild hematuria and proteinuria. Pro-BNP was within normal limit, and also RF was positive, and ANA was 1.80, negative for ANCA, CCP, double-strand DNA, SCL 70, and chromoglobin and hypocoagulability workup was negative. Negative for hepatitis panel, HIV, syphilis, and also patient mentioned that there was a painless purple spot on his feet, and also he had some cellulitis problems too in the past. I
Wait,
will
sorry, you
stop
had what
here.
in the past?
Cellulitis.
Oh, cellulitis in the past. Okay. Well, I think I would have to count all of our Duke's criteria here, but I think we might be satisfying. We
And
might be
also,
satisfying.
I'm sorry, but also like he denied IV drug use, but but the family mentioned that he was currently using those too. So.
Oh, family mentioned he was using intravenous drugs. Okay. Um, well, I think that gives us a source, and then maybe a couple of prime potential bugs if that. We don't have a positive blood culture yet. But I think even if we don't have a positive blood culture, we have anemia, we've got all of the ESR elevation, we have RF positive, we have a fever, new murmur. So we're checking off lots of things that are still pointing our gravity towards the heart as a source. Um, and I I think I would be concerned again for staff as a really destructive cause. But what are your thoughts?
I'm right there with you. I think you're spot on. Yeah, I think the why, the what, and the where are all lining up. And I think the additional where is not just the brain or the eye, but probably the kidneys too, because hematuria, proteinuria, AKI might suggest immune complex glomerulonephritis from endocarditis. So, yeah, really worried about the patient. Unfortunate that there's injection drug use for anybody, and let alone sort of concealed injection drug use. I think a lot of work to get this patient the treatment that he might benefit from. But yeah, I'm holding my breath for those blood cultures results. And if they're negative, we have a lot of work to do. If they're
Yeah,
positive, we at least have some clarity.
yeah, I agree.
Mike
Hey,
TV.
sure, yeah. So, okay, so after, of course, the antibiotic was given. After 4 days, he became drowsy with the vomiting. So, emergency CT show a new left temporal periocular intracranial hemorrhage. CTA revealed a small enhancing lesion consistent with a rupture infectious aneurysm. TTE was a normal ejection fraction, moderate MR, and TEE was showing vegetation with a worsening valvulopathy. Culture was showing the gram-positive foci in cluster, and serial blood culture was showing the same thing. Emergent neurosurgical intervention was asked, and then also ongoing IV vancomycin. So, what do you expect the diagnosis will be?
Yeah, I mean, this really unfortunate case, injection drug use is so challenging to treat, and then what sounds like maybe staph in the blood often needs to be like debrided. Uh, so I'm really concerned about this patient. Now they have this IPH, um, or ICH. I yeah, um, a lot of the things that we've already touched on, I think are kind of emphasized by this aliquot that this is a really scary illness that causes really really severe and hard to treat lesions.
Yeah, I'm right there with you, Sarah. I think the gram-positive cocci really limits the DDX to staph, strep, enterococcus, and some other ones. The fact that it's in clusters and not chains really suggests staph, and the virulence would probably prioritize staph aureus, as you alluded to. And I think the patient is suffering all the sinister complications of endocarditis, which have to do with blockage of things, like his vision and his strokes, but also the blockage turning into bleeds, as is happening in his kidney with hematuria, and unfortunately, and more seriously, as is happening in his brain. And I think when you have endocarditis, the treatment modality is often antibiotics, but there are some indications for surgical treatment, and those are that you have persistent positive blood cultures despite treatment, or that you have continued embolic phenomenon despite treatment, which I think he suspect he has. And so the major contraindication to giving him surgery is that surgery requires him to be on anticoagulation. And anticoagulation is a big deal in somebody who just bled in their brain. So this will be a very difficult case to try to manage. But I think you absolutely nailed the diagnostic and therapeutic management till this point. Let's see what he and her colleagues did for the patient.
Yes, so the diagnosis was the MRSA, infective endocarditis, with a septic embolic stroke and a retinal raw spot. And as Ravi mentioned, that the joint pain and all those glomerulonephritis, like infective endocarditis, immune complex disease, RF was positive, but CSP was negative, and low complement is due to immune complex consumption. ANCA could be falsely positive, but here in this patient was ANCA was negative, and ESR-CRP was very high with a fever and night sweat and murmur embolic strokes and a raw spot and positive blood culture pointing to the infective endocarditis. And Sarah, it was amazing discussion. I really enjoyed your discussion. It was great.
Yeah, I completely second that, Sarah. Thank you for this case. I think it's ripe with so much bread and butter learning about neurological disease, localization, thromboembolism, and endocarditis. Endocarditis. I'm really looking forward to Manaswini's teaching points generated by this awesome case. I know weren't involved in the care of the patient. Do you happen to know if did he receive surgery or what was the treatments that were given?
I think that the surgery was given to the patient, and also I think the patient was getting got better actually with the antibiotic. It took really a long time, but my attending mentioned that it's always important when you have a joint pain.
Yeah.
Always think about infective endocarditis. That was the lesson my attending wanted to give to me. So like, yeah, so that was a very great case to
Right.
learn.
Yeah, absolutely. Thank you so much. What are your reflections, Sarah?
Yeah, I think my reflections on this are really think if you see systemic symptoms, think systemic disease. And also just remembering how destructive staph is um, and also I will always remember now that infective endocarditis is a contraindication to DNK.
Yeah, no, I love it. I think those are very practical and takeaways that you'll probably vividly recall in not too short an order when you're called to the
Yeah.
right. It was such a treat to hear his case and discuss alongside you, Sarah. I felt like we were kind of simulating the real life care of what it's like to be working with a very savvy and advanced trainee, or definitely ready to jump into intern year. And excited to see you continue on your journey to learn and grow. And it was cool to do that, although too briefly for just an hour on your birthday, nonetheless. But thanks for an awesome hour, and big shout out to Aaron for the scribing and for the images. Really appreciate it. All right, Manaswini, mic to you.
What an enriching case and an absolutely wonderful discussion. Um, the teaching points are full. So, we learned that the time course is key in any neurological complaint, where the disease, what is the disease, and why the disease. So, where we localize it to central, seeing the hemi neglect, and it's important to note what bloodiness is in this case, whether it's visual loss or diplopia. And neurological causes of bloodiness are rare. What is the disease? We saw that it was a systemic illness. We think intravascular versus extravascular. So inside the blood vessels, whether it's a vasculitis, endocarditis, or NVTE, versus multifocal patchy disease outside the blood vessels like cancer. And in case of systemic disease plus acute neurological syndrome that we see here, it's important to lean towards intravascular conditions, probably an embolic phenomenon from endocarditis, as we see here, or a CNS vasculitis, an infectious cause of it. And it's important to also understand how much of the disease is extravascular if it's associated with rheumatological or ocular symptoms, and why the disease in these. It's important to note if it's an pre-existing cardiovascular vulnerability or there's a vulnerability to the bug in this patient. And the management of a possible endocarditis, we saw vancomycin plus ceftriaxone is empiric, and doxy is given in culture negative, although culture negative would not require empiric treatment because we see that there is slow progression. And if there is continued embolic phenomenon or it's resistant infection, it might indicate the patient needs surgery. But here we see contraindication to surgery as there is contraindication to anticoagulation because the complication in endocarditis, if into brain blood vessels, maybe that the patient might have an devastating intracranial bleed if we give tenecteplase in this patient especially. And if it's a plain thrombus that is present, it usually blocks and does not cause a hemorrhagic conversion unless there is an inherent inflammatory or infectious component that erodes the blood vessels. So we see that the blockage has from the endocarditis septic emboli has caused bleed in the kidney, brain, and it's and depicting a case of infective endocarditis, especially if it is staph.
Unreal, absolutely unreal. I feel like, I don't know, I feel like it was almost next to impossible to capture all the heavy hitting teaching points, but somehow you managed to capture the whole theme of the three W's and the detailed prose in the middle. That was absolutely super bonus. Thank you so much. And gosh, your fingers must be tired from all the typing, but I'm glad that you were able to summarize it so clearly and crisply. We have to end by by wishing Sarah another happy birthday. Hope you have a wonderful rest of your day. Thank you for kickstarting it with us, and have a great day, everyone. Bye.
Bye.